how can depression be understood through the lens of trauma? So the first thing is to understand that a trauma-focused approach to mental disorder is effectively transdiagnostic. And what we mean by that is it covers a range of diagnoses. Depression, the two core symptoms of depression really look at anergia, which is a profound lack of energy, and anhedonia, which is that enjoyable things are no longer enjoyable. Most of the diagnostic criteria is then set that a person feels that way every day for at least 2 weeks in a row. And so whenever we begin to look at the depression, there are other symptoms that go along with that, and some of the key ones would be, for example, abnormalities with regards to sleep. Mostly sleep is diminished, people sleep less, they have difficulty getting into sleep, they have difficulty remaining asleep, and they wake earlier than they ought to. During the daytime, we may see the low energy, poor motivation, but we also may have what we call diurnal mood variation, with the mood being better or worse in a typical pattern throughout the day. A person may describe feeling better at the start of the day, but worse as the day goes on, or the other way around. So whenever we, as traumatologists, begin to look at a depression, what we're looking at then is something which is driving that. And so what I teach my students is to look for where is the ouch. And so we're very much looking at the whole system as a body, mind, and spirit. And what we would be doing is asking the person to tell us how they feel with regards to their depression. And then within the EMDR methodology, what we would do is we would invite the person to connect to the felt sense in the body and do a float back, which often takes the person to painful events in their past. Now, this could be simple things such as, for example, a felt sense that in school they really never achieved to the degree that they believed or that their parents expected them to. And so a person may have then taken on board a narrative which is, I'm not clever enough, or I'm worthless, in a society that's very driven by academic attainment. So what we would seek to do is for each individual, try to work out if we can find specific painful touchstone memories, and then we would seek to work on those to reprocess them. Now, we're not looking for a necessarily specific detailed narrative, because for some people, whenever we've had these experiences, it can be like a collection of a lot of these, which have just been a drip, drip, drip effect on a person. And so they just have a general sense of, well, in my childhood, I was never really loved or wanted within my family. They may not be able to put their finger on it, but what we find is that some of these things go back to a point in a person's life where they have, for example, been pre-verbal. So whenever they've been very young, sometimes a person has experienced something that they don't have a specific narrative for, but they have just been left with this felt sense that then has been interpreted later with a certain negative narrative. We talk about this as a gestalt, or an irreducible sense or feeling, but that can be worked upon for the person and help them to then process this unprocessed material, and that we believe that that then helps to reduce the symptoms that it's manifesting, which could be, for example, depression. So what I've just outlined there is what we call the adaptive information processing model. And this is the model which underpins EMDR. EMDR therapy having been created by Dr. Francine Shapiro, and the AIP model was described first of all by her and Dr. Roger Solomon, who was my trainer. And so whenever we begin to look at it, when information flows normally and is processed, then a person can put things in context. But whenever information is left in an unprocessed state, then it sort of sits, and it's the thing that drives in the pathology, which could be a depression.